And as they're coming forward, I urge Health Committee members to please report for duty. I know many members are at other hearings this afternoon. Please come help us establish a quorum. Mr. Huffman, good afternoon. The floor is yours.
Thank you, Mr. Chair and members. And along with my joint author on this bill, Mike Feuer, I'd like to present on AB 1826. Chronic pain is a growing national public health crisis and now affects an estimated...
Is your microphone on?
It should be. The light is on. Are you...
Okay, that's better. I think you're just so tall and
I'm so...
doesn't catch.
I'll slouch a little.
Slouch, please.
So chronic pain is estimated to affect about 76 million Americans. And a very troubling and dangerous trend is emerging. And that is the frequent denial of coverage by health plans for proven and effective doctor-prescribed pain medication. Often this is referred to as step therapy or fail-first policies. And many health plans are utilizing this approach, which requires patients who've been prescribed a pain medication by their doctor to first try an alternative medication. Oftentimes it can be an over-the-counter medication, even Tylenol, and to try that until it fails, and then try the next most cost-effective medication. And as you'll hear from some of the witnesses here today, often this puts these patients with chronic pain on a treadmill that can last months and in some cases even years before they finally get to the medication that their own personal physician prescribed for their pain. And I believe that is unacceptable, members. Insurance companies argue that they use step therapy in an attempt to drive down health costs, but not only is this policy extremely dangerous to patient health, research actually shows that it can increase the direct cost of health care in the long run due to unscheduled hospital admissions, excessive use of emergency rooms, and of course, as you can imagine, folks that are suffering from chronic pain and unable to get the medication to relieve that pain have tremendous effects in their lives. They can lose their employment, it can cause effects in their family, and we believe it can even lead to suicide. The indirect costs include lost wages and productivity of people with pain and their caregivers. According to a 2006 study by the National Center for Health Statistics, the annual cost of chronic pain in the United States is about $100 billion due to this lost productivity, income, and health care expenses. AB 1826 would simply prohibit a health plan from using step therapy when a doctor prescribes pain medication to their patients. What this is about, members, is who should make the call for the medication that best addresses a patient's chronic pain. The physician, the doctor who knows that patient, or a bureaucrat or an executive at a health plan, and I believe the answer to that question is clear. I will hand the microphone over to my joint author, Mr. Feuer.
Thank you, Mr. Huffman.
Another member who has to slouch a little bit for the microphone. I'll be extremely brief. I'm cognizant of the committee's time constraints. I just want to say this regarding the opposition. Some of the opposition states that step therapy might be useful because it ostensibly helps patients use safer regimens rather than less well-established therapies that could cause harmful side effects. Well, here's the answer to that. Doctors who work with their own patients already take into account the potential side effects of medication that they prescribe. If they're prescribing pain medication of a certain type, it's with the knowledge that the benefits of that medication will outweigh any potential side effects. Mr. Huffman said it concisely. Treating physicians, not insurers, should determine the pain therapies that patients receive. I urge an aye vote.
Thank you, Mr. Feuer. Witnesses in support?
Yes, thank you, Mr. Chair. I have with me Cynthia Toussaint. The sponsor of this bill is an organization called For Grace that represents chronic pain sufferers.
Thank you. I am a living example of the terribly botched healthcare system that we have in this state. Nearly 28 years ago, I was a 21-year-old ballerina with a very bright future when a minor ballet injury triggered the chronic pain disease known as complex regional pain syndrome, or CRIPS, in my right leg. For the first 13.5 years of my illness, all of my HMO physicians told me that my physical problems were all in my head. As a result of that abuse, I spent nearly a decade of my life bedridden, and for 5 of those years I was not able to speak. Imagine that. while the crypt spread throughout my entire body and ravaged my vocal cords. To make matters worse, a dozen years ago I developed fibromyalgia as an overlapping condition, so I now not only deal with constant pain, but I also deal with constant fatigue. And if you think about it, how do we torture a human being? Well, we inflict physical pain and deprive them of sleep. Welcome to my world and to the world of many of my sisters. Today I am founder and spokesperson at For Grace, where we ensure the ethical and equal treatment of all women in pain. And it is on behalf of that community that I'm speaking to you. Over the past 28 years, I have faced countless barriers to healthcare, including Fail First, which is a disaster for me and for all women in pain. Fail First must have pulled a page from the HMO playbook because its business plan is identical. Simply put, it is profit over patient care, and it is that unethical delay in treatment that, just like my HMO horror story, causes unnecessary harm and suffering and ultimately turns many of us women in pain into lifelong patients. Fail First is good business for the insurance companies as it is lining their pockets, but please make no mistake, Fail First is bad medicine for all women in pain who, like myself, depend on the right medication at the right time. My personal experience with Fail First began 18 years ago when my insurance company took me off of my Accid and put me on a cheaper med. As a result of that switch, I couldn't speak. And I even experienced severe pain when I whispered. I had to fail twice before I was finally put back on the original medication that my doctor prescribed for me so that I could talk again. More recently, I was taken off of my Klonopin that I'd been on for 15 years. As a result of that switch, I went through withdrawal symptoms, including hallucinations and intense anxiety. This is an extremely traumatic experience for me. I am very proud that For Grace is sponsoring AB 1826, and I am here today in strong support of this life-preserving bill. And on behalf of the 3 million women in pain who live in California, I thank all of you for your support, your great support today. We need it. Thank you.
Thank you.
My name is Dr. Scott Fishman. I'm professor and the chief of pain medicine at the University of California, Davis. I'm also president of the American Pain Foundation, the leading advocacy group for patients in pain in the country. I'm speaking today in support of this bill as an individual and as president of the American Pain Foundation. I work on the front line of pain management, and I'm the guy who's put in the box when an insurance company makes us face a choice. And that choice is, do we give the patient the drug that's best for them, or do we give them what the insurance company thinks is best for them and what I usually think is not in their best interest? Sometimes they get it right, but not often. And the question, as you've heard here today, is who do you want to make that decision? I have had multiple experiences where I have had to offer a patient a less optimal choice, a choice that has higher healthcare risk, a choice that potentially will face that individual patient who has entrusted me with their best and safest care with the less optimal and riskier outcome. I can give you example after example if you'd like. And these are very, very basic things. The thing that I think you need to understand is that in medicine, advances in pharmaceutical solutions have not only been to make these medications more effective, but they've been to make these medications safer. And it's the safety margin that we focus on as risk managers, as physicians. We have an obligation to our patients to make sure that they are safe. I feel as a clinician that the Fail First policies undermine that ability for me to keep my patients safe. And I just want to emphasize that. I want to emphasize that there's enormous cost avoidance in choosing the best drug first. Okay? You may see financials that show that this costs money. It's exorbitantly expensive to make the wrong choice when you're treating someone in pain, because someone in pain is going to churn resources in healthcare. The cost is exorbitant. We know that data. The cost in human suffering is immeasurable. Thank you.
Thank you for your testimony. Other witnesses in support, name and organization, please.